Hello, everyone. My name is Dirk Schroeder, and I'm really pleased to be moderating this exciting panel on telehealth and virtual care in international perspective. Accompanying me on the panel are two world-renowned colleagues, Dr. Jefferson Fernandes, who's a Brazilian neurologist by training. He also is very active in the telehealth and telemedicine ecosystem. He's the vice president of the Brazilian Association of Telemedicine and Telehealth, as well as a director of telemedicine education program in São Paulo. And he'll tell you some additional information about himself. He'll be the first presenter today. I also have Dr. Pat Quinlan with us today. He is the CEO of Hippo Technologies. He's also the CEO emeritus of the Ochsner healthcare system, the largest healthcare system in Louisiana. We will spend some time with you today talking about the international ecosystem of telehealth and virtual care. Each of us is going to take about 5 minutes to give an overview from our perspective, and then we're going to save about half of the time for we hope, really interesting and deep discussion about how we can accelerate scaling up of telehealth and virtual care globally. So with that, I'll pass things over to Dr. Fernandes. Please take it away. Thanks.
Thank you very much. Thank you very much, Dirk, for the introduction, and thank you for the organizers of this meeting to invite me to participate here. Just to add, in my activities, professional activities, I'm also the director of the education program of the International Society for Telemedicine and eHealth. And my approach will tackle three main items regarding a framework of the perspectives of telehealth and virtual care. Challenge for any country is the integration of digital health in the health system, the legislation regulation, sometimes going back, sometimes going forth, and finally training and skills in digital health for health professionals. We know that we have huge challenges in health, as inefficient use of information, fragmented care, usually care is in silos, duplication and waste, and also the protracted adoption of innovation. And we have to understand that any solution that we provide in digital care or telemedicine or telehealth that are part of the digital healthcare system, it should be integrated into the healthcare ecosystem, should understand the needs and the pain of the system, and then try to bring solutions that are relevant for the system. And being relevant for the system means that it should be relevant to the citizens as well. Telemedicine and telehealth are within this digital health system, and it should also follow the same path. Telemedicine and telehealth have a lot of application. We can go from promotion of health, primary, secondary prevention, screening of patients, diagnosis, therapeutic interventions, rehabilitation, monitoring of patients, and management of chronic patients. And the best way to do all this is looking at the continuity of healthcare. And I'm going to talk about this in a few moments. And of course, virtual care also involves education, research, and the management of the health systems. Going back to the continuity of healthcare, we should take into account the patient journey. And we as individuals, we have all these different aspects. The promotion of health, health living, as said before, prevention, diagnosis, treatment, and the care at our home. And the connected care can be in several instances of all this journey to help to bring more quality to this health system. Acting in and around the patient's lives to provide care whenever possible, when, where, and how they need and want. This is something very important. So this is one of the directions that the virtual care is going to the safe and comfortable place of people's house. And when I said whenever possible, is because we have to learn not only the benefits of telehealth, and virtual care, but also its limitations. So we should know when a teleconsultation should be transformed in a face-to-face one, when we need more information or the patient is not in the circumstances or have some problem that is not adequate to do it by an online platform. And of course, we should practice telehealth that responsible. What do I mean by responsible? With ethics, with quality, and with safety. So we should take account the legislation and regulations that vary among countries, and even within some countries we have different states, such as the USA, we have different approaches in regulation. Of course, the pandemic has changed that, and we might discuss this during the other discussion sessions. But many times the physicians or the health professions get some confused because, well, how do I practice responsible telemedicine or responsible telehealth? Telehealth is not a tool. Tool is the hardware, is the software. Telehealth is a method, and as such, it should be learned. So training and education for physicians and for all health professionals is very, very important. We have to evaluate different aspects of the teleconsultation, for instance, such as the physician-patient relationship of health professional-patient relationship, how to provide confidence, how to be bringing humanity to this relationship, and also all the aspects that regards the technology, legislation, and so on. In the International Society, we have this new education program, which I was honored to be the director, that we try to bring internationally several opportunities for people to learn, together with several other organizations, such as we have here in this meeting, opportunities to learn, opportunities to share experience, and also to share visions. In my view, the professional certification is something that you should follow. No, it could be a general certification in telehealth, could be in mental health, could be also in primary care. But this is important for all professionals to learn more about how to practice with responsibility. And of course, the programs and services will be helped if they also pursue some kind of accreditation, external validation that brings the knowledge to people that these services or this program is being evaluated from outside source and is something that has the credibility to provide safety and quality of care. So these are my specific points I would like to make. So we could discuss more about them after all presentations. Thank you very much for your attention.
Thank you very much, Jefferson. That was an excellent overview of the telehealth and virtual care and education. And I thank you for that. You're a real leader in the field. So I'm going to continue our presentation section of the panel now with a few slides. So, as I said, Dr. Fernandes gave us a nice overview of the value of virtual care and telehealth and telemedicine. What I'm going to be doing now in this next section is really focusing in on how we can move these promising and exciting technologies to scale. And I'll particularly focus on the lower income and middle income countries in Southeast Asia, Latin America, and Africa. Just some orientation. I personally co-founded a digital health company focused on Hispanics called Hola Doctor, which was acquired a few years ago, and I'm currently managing director of the Advancing Health Innovation in Africa program at Emory. So this is an area I feel very passionate about. So as Dr. Fernandes says, I think anybody participating in this conference has a good understanding of the value and benefits of telehealth and virtual care. Just to summarize them one more time, these are really optimal technologies for enhancing care coordination, improving clinical outcomes, enhancing the consumer experience, improving efficiencies, and expanding consumer and clinical access. And in part, I'm putting this up here now because This is really what many of us are familiar with from in the US, Canada, and Europe. I'm going to look now at how telehealth and digital health is being used and the promise for it for less developed situations. So in low and middle income countries, digital health really has tremendous potential. It's been recognized as such. And in part, it really has the potential to fill in some gaps that are unfortunately still in place in many less developed economies. So this, for example, is looking at digital health may be able to overcome some constrictions around poor adherence to guidelines. Insufficient supply of qualified health workers is a very serious issue. There can be just a few or a handful of specialists in the whole countries. And Dr. Quinlan is going to talk some more about that. Prior to the pandemic, there were some real shining stars in the digital health arena in less developed countries. This is just one of many examples. Sehat Kahimi in Pakistan. This is a network of all female physicians caring for lower and middle income consumers throughout the country, and really had been building already a really fantastic platform. COVID-19, of course, really accelerated the utilization of telehealth and digital health. This is a recent graph from McKinsey, which shows the big spike in April of 2020, which we're all familiar with. And then we knew that things would come down and soften. I think it's very interesting that really in the US, at least, this utilization has remained at a pretty stable level of about 40% of people regularly using digital health. That spike, of course, occurred in other countries as well. This is a great new study from Willis Towers Watson, which shows the percentage of insured members that use telehealth for primary care physicians. So in Latin America, that went from 5% using it on a monthly basis to over 50%. So this was, again, similar to other areas of the world, huge increases in the utilization of telehealth and digital health. So the question is how can we build on this success? Unfortunate, for the reasons unfortunate, of course, the COVID-19 pandemic, but we sort of were accelerated in this intervention. And the path forward, I will say, is not totally clear and not necessarily easy. So that's what we're going to talk about a bit on the panel today. I will say there are a number of groups, international and global groups, working on this. This is a great report from the Information Technology and Innovation Foundation on building a global framework. Essentially, the idea is we have these technologies that have been proven in other countries in the US, Canada, Europe, and elsewhere, Asia. How can we get these into lower and middle income countries sort of most quickly? A lot of these are working well. The strategies and the framework, though, really has a number of pieces. Regulatory, Dr. Fernandes touched on some of these, regulatory, technology, and some others. What I want to do next is look a little deeper at what is the specific barriers and which might we be able to overcome most quickly. So for example, all international bodies understand that there needs to be some sort of national policy around eHealth and digital health. This is a map of the countries in dark blue that have such a policy. So this is sort of number one priority. We need to, encourage these governments to sort of get serious about this. There's still a long way to go. There are a recent review article looking at telemedicine use in sub-Saharan Africa and the specific barriers and policy recommendations around scaling that up beyond the COVID-19 pandemic, identified 5 clusters of barriers: technology barriers, poor quality internet, organizational barriers, lack of expertise and training, kind of things that Dr. Fernandes just talked about, lack of national guidelines, individual. Doctors feeling a bit threatened by this and maybe a lack of control over patient management, financial and the costs, and we'll take a look at this, and also cultural barriers. So I think there's long lists of these kinds of barriers. I think, again, the key thing here is let's identify the ones that we can sort of start knocking off and do something about. These lists of barriers and sort of the challenges are very similar. I'll say that was in sub-Saharan Africa, but very similar to the list that some colleagues and I identified in Latin America and recently published in the Journal of Telehealth and Medicine Today, which is a coordinator of this conference. So just to drill down again at a couple of these barriers and take a look at where we might see some opportunity to overcome them. First of all, technology. Unfortunately, there's still a ways to go with making the internet available throughout the world. The good thing, I would say, is a little bit complicated, but mobile internet is really the key to getting the world online and making telehealth and virtual care available to the entire global population. Today, just over half of the world has access to mobile internet, 51%. In the gray here is the people that are living in places that don't have or that doesn't have mobile internet coverage. So that's really gone down. This group here in the dark yellow and the orange really is the important group. So these people are living in places that have access to mobile internet. They could have it if they had a smartphone, but they aren't online. So the question is why? The key barriers or the key reasons why people are not using it really come down to two. One is the lack of awareness and understanding of the benefits of mobile internet. And the second is affordability. So this in a number of research studies have identified sort of the two main areas. And I would say that both of these are something we can do something about. And we'll talk about that during the discussion. I'll end by saying that I think on a very positive sort of glass half full way, there's a tremendous amount of investment going into digital health. This is investments in digital health in the US. The COVID-19, of course, supercharged funding activity in this area. Already in 2021, we've surpassed the amount of investment as all of last year. So this is big. In less developed and middle income countries, there's a lot of activity, a lot of investment in impact investing, a lot of public-private partnerships, and even USAID and sort of traditional philanthropists and donor agencies are recognizing the benefits of social enterprise and partnerships that accelerate these technologies. And I'll just end by a little word of caution. This is from the UNDP, which says that, I think especially in some of these countries where we're investing in growing virtual care, there's the risk of widening the digital divide, leaving large groups of people behind. So as we build these inclusive, vibrant, and culturally tailored digital health systems, I think we can keep that in mind and be inclusive, which is really going to benefit the whole system down the road. So I will leave it there. This is my information, and the resources and reports and papers that I referenced today, I'll post to my website, and they'll be available for free and for download if you have any questions or would like to get a hold of them. So with that, I'll stop my comments, and I will pass the baton to Dr. Quinlan. I will bring up your slides, Pat, here.
Sure. Thanks so much. It's a pleasure to be here. I'll have a complimentary view to what we're talking about. And I'd like to begin with the context of what I hope to share with you. It's basically a focus on the end user first, that much of what happens today as we talk about technology and then how it begins to filter down and come to the end user. And often end users are saddled with something they can tolerate rather than something they want and desire that helps them practice the way they would like or help the way they would like. So we started with that premise and then work up. And my approach to that was based on the fact I started as a solo practitioner in rural America and ended up as a CEO of a 40 hospital system with typical integrated system that takes care of large populations. And it's with that population health approach that I take this. And in the early 90s, I started one of the early teledermatology programs and learned a lot about the real power of this is not so much as providing answers as it is providing teamwork and upskilling the mentee and developing close relationships between the people who together give the care, who may not be there in person, but you can develop relationships that can be often closer than they were if you were in person. So that is, to me, the glue of great medicine is how do you build professional capabilities that grow and become sustainable in the process? And to do that, we take a different approach, which quite often we start with the technology. Instead, we say, what use case are you focusing on? What problem are you trying to solve? And then what could you aspire to if you could do it differently? And in the process, understand the inventory of assets that happen to be present that may not be accessible because of the way we do things now, but how do we unlock the potential of these assets? Dirk talks about low and middle income countries. They have assets, but often they aren't accessible to the people who need it most. So we've tried to devise a system that integrates the clinicians horizontally so they can become teams, but vertically understand the problems of systems and regions and countries to make sure that when you solve this problem, you don't create new problems. So how do you make this doable? How do you make it affordable? How do you make it capable of being implemented? So the requirements are usually low cost, high flexibility, durable, rugged, because you don't know what situation is, to be more like a utility than some complicated technological device that, as you know, is prone to failure. So that's the approach we've taken. I think that's when we talk about the way to approach this is starting, what does the end user want? And is it user-friendly? Is it intuitive? And if that's the case, then you can begin to address what our manpower shortage is everywhere. More pressing, just absent in many parts of the world, or insufficient in much, right? So what we've devised as a system, and I invite you all to participate in your own version, is a manpower multiplier. How through virtual care can you work with someone in a remote location with a you or their experience, that you have a partnership to help them bring your expertise to them and learn in the process. They, in turn, as they train up, could have their own people that they manage, sort of a manpower pyramid that then can grow as each person becomes more capable. So it involves increasing access from existing assets and then upskilling people so that this knowledge gap is addressed, because expertise is what's in short supply. Sometimes it's very basic, sometimes it isn't. And the more capable workforce you have through constant interaction, I think is extremely important. What you basically create is a knowledge network. You take knowledge where it resides, anywhere in the world, and bring it to people who need it on their terms to make this partnership work. In the process, build capability, don't just come and go, which happens much of the well-intended and good results we have in the world. People come and do good things, but then they leave, and what about what happens later? This virtual care network that you could create would maintain that connection, build that connection, so it becomes more and more capable, and then link with existing capabilities. So we find that a you are there perspective is essential, that what we settle for now are indirect ways, maybe phones, and that may be fine in certain circumstances. The key is to match the technology with the problem. You know, I would say if a letter works, send a letter. But for many cases, in particular, is to get that you are there experience and have bring the full value of, say, a specialist, someone who's very experienced, into that situation. You often need an immersive kind of experience. By immersive, I don't mean, you know, the immersive virtual reality, but I mean an augmented reality where there's two things can happen. This is the other point, is that when you're with telemedicine, sometimes because of connectivity problems, you can't have real-time connection. So you also should have a store and forward so that this partnership can occur even in areas with no or poor connectivity. And whatever you use should be basically geared to a low 3G environment. I know 5G is coming, but low 3G is much of the world, particularly where they need it most, or LTC. So having that flexibility, what kind of connectivity do you want, both in terms of technology, but also in terms of knowledge. So this asynchronous communication that you can do by store and forward allows the partnership to continue even in difficult situations. Then the third part is, this is basically a knowledge network, and much of this is predictable, right? Everything's different at times, but there are patterns that you can see. So if you have a device where you can store this information and they can call it down, they don't need to connect with someone, which creates two things: instant availability for the things that you know that they will need, be it wound care, or you go through your list, checklists, which we know drive great medicine, but often aren't used because they're not available, and workflow. So it's about the workflow that you can build into this process to make sure that you have uniformity in care and you're not skipping things. And then the other is the asynchrony. As you know, when you're bringing somebody else in, somebody often is inconvenienced, and this timing is difficult. So with asynchrony, with the store and forward, you can work out, much like you would with the text message, what information needs to be seen in what time period. So that's the way I look at this, is that we need to start with the soft piece, which is really the hard piece, which is what are you trying to accomplish? What workflow will enable that? And then how do you create that so it's able to execute in difficult and different environments? So flexibility is key.
Thank you, Pat. And I've got the slide up here from Nigeria. Just if you could just in 1 minute tell us about these implementations of the virtual care system that you're involved in. That would be
sure.
That'd be great.
So we started in Nigeria. I have a trusted partner there, but the idea was that we know that the world has this tremendous need, and we need to demonstrate its efficacy in a real life environment. So in the case of Nigeria, we were able to use a low 3 environment, which has its own challenges. And we were able to demonstrate rounding, teaching, proctoring, and consultation, and ambulance. Those are the kind of common scenarios. Same basic approach, right? But these nuances matter. And we did this at the Royal Dutch Shell Hospital in Port Harcourt. The second proof were in times of crisis, we sent our devices over to Wuhan when the pandemic broke. And you can see that people had trouble. They didn't have the PPE, so they did other things. So in a crisis with easy implementation, the flexibility that we discussed and that you are there kind of experience, these senior physicians were able to be spared exposure to COVID and send others in and also save that scarce PPE and get care directly to the patient from an expert, exactly as they would if they were present, but then overcoming the barriers of time and distance, right? They could be anywhere in the country and come in and help. And likewise, be prevented from being exposed when it would be important to be able to avoid that. So that's important in this pandemic and the next one.
Thank you very much. Yeah, that's great. I wanted to include those couple of real-world case studies and use that as a segue to the discussion we're going to have now for the next 15 or 20 minutes. Jefferson, we're still unfortunately in the middle of this pandemic, and I tell my colleagues I'm not sure it's even arrived in many places in the world, less than 5% vaccinated in Africa and many other places. What should we be doing now? What are some of the things that global experts in telehealth and virtual care should be really promoting and leveraging? What more can we do to ease the burden of this pandemic, and also use this then as a sort of launch pad, as I tried to set up for really making virtual care part of the normal day-to-day part of healthcare? Jefferson?
Yeah, thank you, Dirk. Well, I think there are so many things to do that I have to select some of them.
Yeah.
But in a broad approach, I would say that countries should start by bringing the policies that are needed to the implementation of telehealth and virtual care in the public system and also in the private system as well. And for that, we need also people that have good knowledge and ability to manage these systems and the services that are within it. And of course, there's the need of investment. This investment will have its return in many ways that we already know. And also awareness and education, for not only for patients, but also for health professionals and physicians that are still resistant, or they are not willing to use this approach. Can I give an example? In Brazil, where I live, we have, as in any other country, a huge increase in emotional, psychological aspects of the pandemic, the burden that is bringing emotionally. We have psychologists doing a very good work on that. They are really increasing the number of teleconsultation support, but the psychiatrists, in turn, they are not very involved. They use teleconsultation for their own private patients, but in the public system and elsewhere, we don't have these services being provided. So I think this happens in other countries, low and middle income countries as well. So I think these are some of the aspects that we should work on, so we could disseminate the benefits of telehealth and virtual care in countries or regions, and even within some parts of each country.
Yeah, thank you very much for that. No, I was as I was reading some of this material about Southeast Asia and Africa, I was thinking about your experience with training in Latin America, which I think in some ways is a little bit further along in some of these, working with some physicians. So, I would encourage you and others, I know you're doing a lot of work in this area as well, is to take some of those best practices. And I know that's in part why we're on the call today. So that's great and appreciate that. Pat, you're on the ground there working in a number of countries. I put up a list of the barriers that were documented in sub-Saharan Africa. Which of those are you sort of faced with most often? Which, if you could wave a magic wand and would want one thing to go away or have, what would that be? What do you see sort of on the ground?
I see it everywhere that, adults and institutions are hard to change. When under stress, we tend to double down on what we know, which is human nature. What we have to accept is that virtual care done in an imaginative way is the answer. The West is just failing faster. That's all. We have to get in and change people's behaviors to reduce the disease load. Unless we do that, we'll just be chasing and losing the race. So how do you get into people's homes? How do you get to where they live? And to me, the first step, and this is why I believe it's such a critical part of this virtual care piece, is how do you get people inside the various communities who are trusted and then upskill them to bring the expertise to where people live. Until you do, we won't reverse this lifestyle. Of course, in many parts of the world, maybe infection, malnutrition, and things like that. But the lifestyle is so important in creating this disease load. Can we bring people into the community remotely and address it where the diseases and the habits and so forth are learned and perpetuated, and we can't go on repairing them. And if we take full advantage of the educational piece, I think the way we educate people in medicine is, let's say, inefficient. You can take these experiences all around the world and bring them to the student who should be whose time is most valuable, and say, what does he need to learn and how best to do that? Not what do we do, but what would optimize your learning, so we can train people who can be the experts, who can then help those who move into the community. It's the multiplier. If you don't multiply, we lose. We're adding right now, and addition doesn't keep up with multiplication the way the disease load grows.
Yeah, that's great. So I want to shift gears here a little bit from barriers to opportunities. There is just a tremendous amount of activity happening in all of these countries, not just from sort of overseas coming in, but also a lot of wonderful homegrown, local innovators, entrepreneurs who are doing great things. So there may be some entrepreneurs that listen to this. There may be some investors. I wanted to take a minute to ask your opinion, and I've got some thoughts as well. We'll start with Jefferson. Where are the big opportunities? The way I frame this is, we're all old enough to have nephews. If you've got a 25-year-old nephew who wants to start a digital health company, where would you direct him? Where do you see some big opportunities in this arena internationally?
Yes, I can name a few, but for a start, I think one important aspect that I mentioned in my presentation is the fragmentation of information. The patient electronic records, usually they are in the hands of a hospital or of a health insurance company or of a clinic and so on. So when the patient moves from one hospital to the other, or moves from one city, even from one state, that information usually lost. I can tell you that in low and middle income countries, this is very frequent. So I think we should turn this phrase that says the patient is the owner of their clinical or health record into really something that the patient has it in his hands. So something like, one patient, one record. Wherever he goes or she goes, this information is available. So if, this could be something that is developed by, the Minister of Health of a country or the state secretary, but it could also be developed by a startup, And this startup can offer its solution for the different system, private or primary system, public or private system. So I think that one opportunity would that to be really cloud-based, patient-owned information. So the patient is really who says, look, this is my password, or this is the password that a doctor can get into my information, have some restrictions of some kind of information, whatever. And then wherever he goes, his record, clinical record, health record is with him. Of course, there is a lot of things to do, and we have some examples in countries that I know, such as as England or Portugal, where in the primary care setting, this is already being solved. So the physician and the patient have one screen. A lot of things is happening in the back of that screen, different systems and so on. But in the end, this is the only information. But this information still is kept within this health systems, and it's usually not easy to the patient to get access to that if he goes to one place or the other. So I think this is one, as I said, you need to identify needs and bring solutions. So I think this is one opportunity for that.
No, I think that's a great example, in part because, the other thing that shows up frequently on these barriers lists is the concern about privacy, the concern about security, the concern about people's data being, outside of their control. So having that centralized and having that control, I think, is exactly right, and putting the patient sort of the individual at the center of things. I think there's a couple areas, and then I'll ask you as well, Pat, that I see real opportunity. Of course, care at home, home health, remote patient monitoring. It's becoming, standard with the pandemic. This forced a lot, as the aging population sort of forced a lot of people to stay at their homes. People didn't want to go to senior care. So I see, all those technologies being developed. And then I think about, rural areas in underdeveloped countries where these could be adapted, culturally adapted, and utilized as well. So I think that's a big area. I think the other one is, of course, fintech, financial technology. Lots of times these healthcare decisions are really a financial decision, buying insurance, paying for things. So I project a real sort of integration and merging of health tech and fintech sort of as people are developing. And we've seen some great things out of Kenya, with mobile payments. I think over 50% of all purchases are with mobile payments now in a number of countries that you don't necessarily think of as technologically advanced. So we'll keep an eye on those. There's again, I think, tremendous opportunity. Pat, do you have a comment on that?
Yeah, I have this practical bent. So, how is it that we do an 80-20 rule or make a difference as quickly as possible? In our company, our thesis is the phone is the universal install base for healthcare in the future. Mm-hmm. And the question is, what do you put in it? And I would suggest that if everyone could come up with something simple, not something complex. We have lots of EMRs. They're prohibitively expensive and complex, and we have lots of personal health records. Can we together in organizations like this say, let's have something really basic? Who are you? What are your medical problems? What medications you're on? What procedure you've done? End of story, right? That's usually how medicine is practiced. And how does that become sort of a common coin that people can use? And to your point, Dirk, people underestimate the difficulty of deciding permissions. Who gets to see that? Because sometimes it might be politically dangerous. They need to protect it. On the other hand, it needs to be readily available. So we looked at blockchain. We've been working on this for some time. What is the very minimum that allow people to use our system or others so we can all talk to each other and say, this is like a utility. Yeah. This is who you are. This is what you have. Nothing more, nothing less. It can link to others and use something like fire files or something like that have common access and easy to get to. I think that's where organizations like this can set the stage rather than waiting for others to do it. If you want to change something, start with yourself. And I think we have the ability to do that. Yeah. Thank you very much.
I think we're closing in on our time. I think we've got about another 5 or 7 minutes. Jefferson, do you want to, maybe we can talk, I guess I'd like to cover 2 more things. One is, I'm sure we each have a personal aspirational vision for what we would see this looking like, 5 to 10 years from now. When I work with students or colleagues, I say, well, what do you want to be doing 5 years from now? What's the world going to look like? So I'll ask each of you that. And then I guess I'll, and also you might add just sort of your parting words of wisdom for people that may be listening, and you can choose what that might be. So Jefferson, do you have a thought on both those?
Yes. I mean, we telemedicine is medicine. Telehealth, is healthcare. So probably in a few years' time, we are not going to stress so much these words and definitions, because these solutions or these methods will be so integrated in our daily practice, that it becomes something that, as you got a stethoscope, or if you got something else to help you, or to help the physicians or health professions to take care of people, diagnosis or treatment, we have anything. So I think that the incorporation of the daily life, not only in hospitals or in clinics, but also in the patient's home. So you're going to see more and more people being taken care of in the comfort and the safety of their own houses. As we saw in this pandemic, many things that patient was usually going to physically to a clinic or to a hospital can now be sought out in his or her own house. So the care in the patient's home will be the focus, and it's going to be also a big business. And going to have not only devices, but all set of things that could help the patient has the safety of his house regarding gases or anything else, and about his health as well in their home. So with that, we could, of course, having some companies or some organizations watching this patient in a private and a proper way, and trying to avoid false alarms, but having the continuity of care. If you have a patient with hypertension, you can see the film of his life, not only photos from specific moments, specific episodic and reactive situations, but you can take care of him or her in this long run, identifying things that you cannot see when you're just seeing a patient in an office or for acute, in-hospitalization. So I think going to this direction will be something in the future. And of course, as you said, remote patient monitoring will increase, a remote patient and follow-up, anything that we define with not only in moments of disease, but also in moments of health promotion. I think this is something that will be very easy. Of course, you have to always say about artificial intelligence that will help us, but a word of caution, artificial intelligence is not so intelligent as some people may say. There's some hype about that. It's mathematical formulas. You don't have common sense. You don't have all the intelligence that everyone have. But working together with physicians and health professionals, you can achieve a tremendous support for the decisions on diagnosis and on therapeutics. But we should know, that's why education is also important, to see if a solution or something is really delivering what it's promising. So what is the evidence? What is the evidence that such solution really controls diabetes or helps to control diabetes and so on? We know several countries such as Germany that started before, physicians can prescribe digital solutions, but they have to prove they are really accurate if they go to diagnosis or effective if they go to treatment support. But the final word should be of the physician, the final word should be of the health professional. So health professions, and I'm coming back to my usual point as someone from the academic side, that it has to learn all these aspects, has to learn how to evaluate if a solution that says that has artificial intelligence, it's really delivering, and what's the risk of false positives or false negatives. So the decision should be So this is could be not only artificial intelligence, but intelligence that assist intelligence for the physician profession. So you're going to get a lot more. So I think these directions we will follow in the next few years.
Thank you very much. That's an excellent vision. And I probably am going to steal your phrase, the film of someone's life instead of the photos, because I really like that imagery. Pat, what is your vision for 5 to 10 years from now?
Well, I think we're not going to change that much in 5 to 10 years, so we have to maximize what we have today. And the intelligence that's underutilized is the stuff that resides in people's heads. So how you can project that to where it's need to train, educate, and change behaviors. And I think that if I were in charge of the world's health, it would say, we're going to start with the answer, which is where people live in their homes and their communities, and recognize one size fits none. Different towns, different regions, different countries, different continents have different kinds of problems. There's, of course, overlap, but focus on what matters the most. Otherwise, we'll end up with an academic enterprise, which we're worrying about how to do things precisely and forgetting that things done good enough, well enough, is good enough, right? So we have to have both, right? Refine your approach, but understand, don't wait forever to do something that you know works. And that's where telehealth, not just telemedicine, can really reach into where people live and change their lives for the better. Now, my idea of nirvana in the future is that we have information from all the sites that we know come in on people, like all your preferences, all your biases, what you do, what you don't do, and have something as powerful as that, understanding all the aspects of things that influence your health and make you just as addicted to that as you are some art of Facebook. Say, oh, here's something new about that pertains to me. Here's something I can make a change. Because if we can change our behaviors to minimize or eliminate our genetic and environmental risks that are in front of us, then we're in a different place. We'll be spending a lot more on things other than health, where things are needed.
Thanks so much. And I'll just close with a couple of words for the entrepreneurs, innovators, and those who are supporting them through investments as we close here. One of the things I did over the last couple of years is I really wanted to understand why so many digital health innovations fail at the pilot stage. So as many of you have probably heard, death by pilot, pilotitis. I mean, there's great ideas, they get out there and then they just don't scale. So I interviewed about 120 people around the world, VCs, investors, purchasers of digital health, and a couple of things rose to the top. And I'll just share those. One is, as people are thinking about this, one is make sure, and Pat, you mentioned this, make sure you truly understand the problem you're solving. People get fascinated with the technology, the shiny thing, and they sort of can't articulate what exact problem they're solving. Another one that was frequently mentioned was how the physicians, providers, nurses, how they will use it. If this takes longer for a nurse, if this is more complicated, it's never going to fly. This has to be made more simple, has to be easy to learn. I'd say another one that rose up and up frequently was who's going to pay for it. So I'll be talking with an early stage company, say that's a great technology idea. Who's going to pay for it? And I get this blank deer in the headlights stare. They said, well, the health plan should pay for it. And I say, the health plan should pay for it, but they probably won't. So if this is going to be successful, if you're going to invest in this, be clear about that. And I would just say, finally, on the positive note, companies only go out of business if they give up. So persistence. I've seen many successful entrepreneurs and innovators just keep pushing at it, pivoting, and those are the ones we hear about today. So I encourage all of you out there to do that. Feel free to reach out to, I think, any one of the three of us. We'd love to hear from you and look forward to working with you in the future. So I think I will close it there. Organizers,